Welcome back to ADA 2024 updates. I'm endocrinologist Dr. Akshay Jain from Vancouver in Canada. And today we've got a very special guest. We've got Professor Dr. Girish Joshi. Dr. Joshi is a professor of anesthesiology and pain medicine at UT Southwestern in Dallas, Texas. He was one of the session speakers at a very impactful session because it was talking about the post-operative and intraoperative considerations for people that are on GLP-1 therapy. So he's here to talk with us about possible clinical considerations that one needs to keep in mind when someone on GLP-1 therapy is undergoing elective procedures. Welcome, Dr. Joshi.
Thank you, Akshay. It's an honor.
Good. So I was attending your session and I found it very clinically impactful. This is something that we are seeing more and more in clinical practice. But for our viewers today, can you share with us as an anesthesiologist, what are the potential risks of aspiration that you're seeing, the rates of aspiration that you're seeing in people who are on GLP-1 therapy?
So although we don't know the exact rate of aspiration with GLP-1 therapy because there are no good studies, but there are several anecdotal reports, including several personal communications where people have contacted me and the American Society of Anesthesiologists. I'm the chair of the task force for this GLP-1 guideline recommendations that were developed by the American Society of Anesthesiologists. Just to give you an example, one of the cases that was reported to me was from a colleague of mine here in Dallas, where a patient, otherwise completely healthy, came in for a shoulder arthroscopy, a simple outpatient procedure in a freestanding ambulatory surgery center. Surgery went on fine. At the end of the procedure, she regurgitated gastric content and aspirated, and then had to be taken to an ICU where she spent 7 days in the ICU. Retrospectively, it was recognized that she was on GLP-1 for weight loss, and it was not disclosed. And this was just before the ASA came up with the guidance, basically, so people didn't know that GLP-1 receptor agonists do increase the risk of aspiration.
That's a really good point. And again, straight from your clinical practice. So for our viewers who may not be familiar with the guidelines, could you tell us in a nutshell, for people on GLP-1 therapy who are going in for an elective procedure that requires general anesthesia, what would be the recommendations for GLP-1 being held?
So I have to first emphasize that currently the evidence to provide any guidance is sparse, and whatever the studies are there, basically questionable or of poor quality. With that said, the reason why the American Society of Anesthesiologists came up with the guidance was primarily to inform our colleagues, anesthesiologists, as well as our colleagues from surgery and other proceduralists of this concern of increased regurgitation and aspiration in patients who are on GLP-1 receptor agonists. So that was the primary aim. Because the evidence is sparse, we basically came up with different approaches to decrease or mitigate the risk of regurgitation and aspiration. It starts with basically having a collaborative discussion, including the patients, so shared decision-making with the physicians and the patient regarding the potential risk. So mention to the patient that there is a potential risk. And then avoiding the elective procedures in patients at high risk. So example of the patients at high risk would be those that are having are basically in the escalation phase of the GLP-1 therapy, patients with prior history of gastroparesis, or patients on drugs that can cause gastroparesis. So basically, I don't know whether you remember, I had an algorithm which I developed and presented at this meeting where I presented the potential risk factors. So if the patients are are at risk of regurgitation and aspiration, that's the patient population we got to be extra careful of. Maybe start off with holding the drug. If the patients are on, say, a weekly therapy, then 1 week before, though the evidence is minimal. Nevertheless, more importantly, avoid elective procedure during that escalation phase in this patient population.
Yeah.
When the patient comes for the procedure on the day of procedure, if they have significant GI symptoms, then avoid elective procedure. Or alternatively, you can do what we call as gastric ultrasound to look at the stomach content. And if the patient has stomach content, then maybe either delay surgery or use what we call as rapid sequence induction of anesthesia, which will mitigate the risk of regurgitation and aspiration.
These are very important points. Thanks, Dr. Joshi, because I think the key concept here is communication with all stakeholders. What I generally do in my clinical practice as well is, of course, avoiding escalation of GLP-1 therapy, especially with surgery around the corner. But at the same time, if patients are still having active symptoms of nausea or symptoms that suggest that they could be having other gastrointestinal discomfort, I would even de-escalate or decrease the dose of the GLP-1 as well, because we know that the GI side effects are quite dose dependent. So in preparation for elective surgery, it's a good idea to start well ahead of time. And obviously, if we are not able to increase GLP-1 therapy, or if you have to de-escalate GLP-1 therapy, it would also be very important to focus on glycemic control, because we know that if sugars get out of hand, that's a different story for perioperative complications as well. So that's, you put forward a very good point. Key is communication between all stakeholders, keeping the patient in the center. One question that I had for you is, we live in a day and age where, of course, one drug can have many indications. So same goes for GLP-1 therapy or GLP-GIP therapy, very similar class. We know that these agents are being used for both the management of diabetes, type 2 diabetes, as well as for management of obesity or overweight. Would the recommendations be any different for someone that's taking these medications for obesity and not for diabetes?
No, in fact, it doesn't really matter what the indication for the drug is. It's the drug that causes the problem. So our approach to managing the patients, whether they are for weight loss, they're on these drugs for weight loss or for diabetes, would not change.
Excellent. And one final question for you. Again, I know the evidence is quite sparse, but it looks like the need of the hour obviously is to look at more prospective trials that give us a better idea. But one final question for you would be, when would it be safe for the patients to resume their GLP-1 therapy, keeping in mind that there's individual variations, but from a postoperative point of view, if it's being held, when would be a safe time for us to start it?
So I do want to emphasize that we prefer not to hold the drugs if possible. If they're not in that high risk category, preferably we would not want to hold these drugs, because they do maintain the perioperative or peri-procedure blood sugar control. So preferably do not stop these drugs unless in that high-risk population. But if they have been stopped, then they need to be resumed as early as possible. And typically, with the current approach to perioperative care, I don't know whether you've heard about this concept of enhanced recovery after surgery. It has revolutionized the approach to perioperative care, where we basically, even after abdominal surgical procedures, have the patient consume oral intake literally within hours after surgery. So that's why we need to start these drugs as soon as possible, assuming they don't have any GI issues.
Excellent. Well, these are such excellent clinical pearls, Dr. Joshi. It's not often that we get to have a face-to-face interaction with anesthesiology and endocrinology for management of GLP-1 in patients who are undergoing surgery. So we really appreciate this opportunity, and thanks for sharing your time with us.
Thank you, Akshay.